Hi, everyone. My name is Chris Molaro, the CEO of NeuroFlow. I'm joined here today with John Eiler, the Vice President of Behavioral Health Services at Health First. It's really an honor to join him. He is a thought leader in this country right now on a new model called Psychiatric Collaborative Care Model. Hi, John. Thanks for joining today.
Thanks for the invitation, Chris. Good to talk with you.
So we'll jump right into it. Everyone talks about integrated behavioral healthcare, but I think that means a lot of things, maybe different things to different people. Can you talk about your model and what exactly it is?
Sure. We're using the collaborative care model as it was really first put out by the University of Washington's Ames Center, starting in the late 80s, some of the beginning work and publications in the 90s. I really have to recommend the University of Washington Ames Center. They have really been a wonderful resource across the country for collaborative care and published a lot of work, but also have a lot of materials available that have helped educate psychiatrists and all sorts of clinicians, including primary care, around collaborative health and collaborative care. So the way the model works is that it is based on a treatment team that is headed by the primary care physician. That's the person that the patient has the best relationship with, we hope. But it adds to that individual, it adds a master's level counselor. In our case, we're using licensed counselors, but that's not necessary. We have both social workers and mental health counselors. And then another party is the consulting psychiatrist. So the consulting psychiatrist does not see a patient for treatment, but they review, in our case, on a weekly basis, review the caseloads or selected individuals on the caseload of the master's level clinicians and make recommendations for treatment, may suggest to the primary care provider, may suggest a medication change or a refinement in diagnosis. So it really is a key component. And I guess in terms of, and the patient, of course, is a big piece of this as well. The patient's very involved in selecting goals.
Right.
Make a few comments about collaborative care in general. It has a few, what we feel are real benefits in helping diminish the stigma of seeking mental health treatment. So a few things that contribute to that benefit is it takes place either in the primary care office. We're finding that the initial visits are in the primary care office, but we may switch to a remote visit later in the treatment. But it is all done under the initial care of the primary care physician. And we acknowledge that primary care physicians are responsible for prescribing over 90% of the psychotropic medications that patients in the US are prescribed. So it really just helps bolster treatment that's already being provided by the primary care physician.
So the model that you described, though, and what I know about the collaborative care model, there's, maybe there's at least the perception that there's a lot of moving pieces and that it's complicated.
It is.
Why the COCM model as opposed to just co-locating these professionals?
Yeah. And I'll give you a little, we actually had some experience before I joined Health First. They did try co-locating a therapist. And there were some errors in implementation. I think the individual wasn't paneled on all of the particular payers.
Right.
And we have to be careful because mental health is typically delivered as a carve-out with insurance payers. So for example, our health plan, Health First health plan, doesn't manage the benefit for mental health. We use a third-party company, a TPA called Magellan, one of the big national companies that does this. So it can be really difficult to get yourself paneled to start a co-located practice. In this case, it's all billing that's done not on the psychiatry side. The billing is actually done on primary care side. So you don't have to go through those third-party TPAs. The billing is all done under the primary care providers. It makes that aspect much easier. And you're right, it is a lot of detail management.
Right.
In 2017, after the collaborative care had been tested across many states and many large projects for quite a few years, it was under review, but finally in 2017, Medicare, CMS opened up a series of collaborative care codes, and they do require certain minute goals for the initial month of treatment. 70 minutes is the goal, and 60 minutes for subsequent months. And then there's some add-on goals if you go over those periods, but you have to manage the time.
Right.
And document all of that. The expectation is that there will be a review by between the psychiatrist and the behavior care manager, our master's level counselor. That review will take place once a week. And then we also make our psychiatrist available for an hour at each of the 4 clinics where we're operating. We make the psychiatrist available for an additional hour for each of those clinics for curbside consultations, if you will, with the primary care provider. So they've got a question about medications or diagnosis that isn't answered in a chart communication in the EMR, that they can actually pick up the phone, talk to the psychiatrist. And frankly, that doesn't even have to be a collaborative care patient if they need some general advice. So it does bring psychiatry even further into the office of the primary care provider.
So there's an economic component to this as well because of the new CMS rules.
Yeah. So, and there are programs that can do very well economically with collaborative care. I know folks that are running these and making them work based on the Medicare and other payer fee for service kinds of payments.
Right.
The only payer that, to my knowledge, that is not working with collaborative care model is Medicaid. It's not acceptable in Medicaid, but I certainly haven't seen any major payers that are not supporting collaborative care. And there's a really good reason for that, Chris.
Yeah.
I'm sorry. The reason is that it's not just behavioral health care.
Right.
It has huge impact on management of chronic disease. And for that reason, healthcare payers, insurance payers love it. If you can get someone activated from depression or out of the house, even managing severe anxiety, and increase their well-being, their exercise levels, medication compliance improves. So there's a lot of the data, and a lot of this came out of the AIMS Center, shows huge economic returns in reduction of chronic disease complaint, emergency department utilization, hospitalization. So there's economic benefit way beyond just the behavioral health of the individual.
Yeah, we were talking before the call here today that, I mean, just the, physical health and behavioral health are really just one and the same. It should just be health, right? And like, how many times do people have a chronic illness like high blood pressure and get that treated, but also have depression or anxiety that makes their blood pressure worse? And if they just got a handle on the anxiety, it would actually improve the blood pressure health issue that they're handling as well.
Completely right. And it is so well recognized that CMS for their Medicare Advantage partners have worked out a very intricate system with their actuaries to put a financial value on a grouping of psychiatric diagnoses, so that for us, where we have a health plan, we can sort of cover our costs with the fee-for-service billing. But when we take a look at the expected improvements in capturing more accurate, what are referred to as HCC diagnoses that go into diagnosis for a Medicare Advantage patient, they'll go into an adjustment, a risk factor that actually brings more dollars, if you will. It acknowledges the higher cost of care and brings the dollars back to the insurance provider.
So you could be better equipped of treating that patient who needs extra care.
That's right. Acknowledging that a patient with depression is going to have higher comorbidities and more medical management issues. It's going to cost more to manage that patient. For us, one of the issues, though, is, and I'll give you some examples, when we take a look at diagnoses across our health plan members who are also part of our medical group, I can look at the charts and see what is the incidence of depression. So I'm running 24% of our older adults in Medicare Advantage have a diagnosis of depression. 23% of them are on an antidepressant. Only 6% of them have an HCC diagnosis that's accurately captured.
Wow.
So we've got a huge gap.
Yeah.
And it's about a $2.5 million a year gap.
Wow.
For the insurance provider. So we basically can fund a lot of other activities in behavioral health with that kind of a pickup. So we're really very eager, and I'll tell you, it's not rocket science. Typically what happens is you'll have a primary care provider who's using a diagnosis like depression unspecified.
Right.
And if we can take that to a next level and say it's a recurrent depression, or it's a mild depression in remission, that gets to the specificity needed in an ICD-10 diagnosis to pick up the HCC code and add about $3,000 for that patient for that year.
Wow.
In terms of what Medicare Advantage will push back into payments. So it's huge, and we're really looking at providing a lot of additional advantage to the patients by having that be available.
So, all right, so let's take a step back. And how do you even get this off the ground in the first, like, I'm a patient of Health First. I come to see your primary care doctor, either in person or virtually. How am I even identified in the first place to be eligible?
A good question. And even before that, we had so few behavioral health services here that, one of the reasons to do collaborative care was it's just the biggest bang for the buck to get patients on board right away. But then you do have the task of identifying the patient. So we have good data in terms of combing through our charts and seeing who has a behavioral diagnosis. So in some cases, we are looking at patients who have a behavioral diagnosis and seeing when they have an upcoming appointment. And in some of those cases, we can reach out to them and try to get a screening to see what how they're screening on a certain number of measures. We've elected to use the PHQ-9 and screen for depression. There are also some indices of anxiety in the PHQ-9. So we're using the PHQ-9 as a screening tool. So using NeuroFlow, we can reach out to the patient. In fact, we've doing massive email outreach. So for example, we're the first group that we are reaching is the group of traditional Medicare patients. That's about 10,000 patients who are traditional Medicare and are part of our medical group. So they have all gotten emails. NeuroFlow has done a beautiful job of working with us to develop a very, very simple landing platform, if you will. So when the patient opens the email explaining collaborative care, the email comes out under the name of the physician and the clinic. So it's coming from a known source from Health First. And it explains the program, tells the patient if they're interested in seeing if they qualify for the program, they click the link, which looks like a Health First link, but is actually hosted by NeuroFlow. And it administers the PHQ-9, picks up the patient's just very brief identifying information, just a birth date and name, and pushes those data into our behavior care managers through the NeuroFlow tool, so we can see if someone is scoring over the threshold score that we use of 10, and if they are over that clinical threshold leading into moderate levels of depression, then we reach back out to the patient, either when they're coming into their next visit at the primary care physician's office, or we can reach out to them via phone call and thank them for taking the screening, explain the program to them, explain the financial responsibility for the program if they have a copay, for example, and try to enlist them into the program. So that's our model now. And the data show us that I think we're running I think it was 44.8%, something like that, in terms of, and not just all screened patients, but any patient that we are doing outreach to, it drops down to about 44% are actually enrolling in the program. So we're getting a good return.
Yeah. So, and everyone that's listening should know that we're NeuroFlow's proud partners with Health First in this. And our whole goal of working with Health First is understanding that there are barriers of adoption to any new care model, not just collaborative care, but certainly with collaborative care. And so trying to remove or reduce those barriers and get as many people identified and enrolled as possible with as little lift as possible. And so working now with you, John, I mean, we've been working with you for months and months and even designing the program, but about you mentioned 6 weeks or so live at this point. How has that adoption been? Have your primary care providers been receptive?
I got a remarkable email earlier today from a primary care provider who was just glowing to our CMO, our chief medical officer. So I was thrilled to get that. But we've seen some outcomes that have really startled the providers already. So we're having our psychiatrist, Dr. Jordan Brown, virtually meet with all of the primary care providers, and that's gone really, really well. They really feel like he is a part of their team. They certainly know that our co-located counselors are a part of their team. So that's what the docs are really raving about. They can walk down the hall, they can see a provider, they can bring a patient who seems to be in distress when they come in for a visit, take them to the provider. Our provider will make time for them and get them onboarded, as compared to waiting 3 to 4 months and not knowing if your patient is even going to enlist in treatment. So it closes the loop also by having the primary care provider stay a member of the treatment team. And the average treatments are about 4 months. We can certainly extend beyond that, and some folks might graduate from the program earlier. It's very much an evidence-based treatment. So we are looking for clearly defined gains in reduction of symptoms, as measured by anxiety measures like the GAD-7. We're also working with drug and alcohol consumption, trying to reduce or eliminate, and with depression, but it's all measured. And that's a key component, certainly as Medicare defines collaborative care.
Now, talk about like the workflow component. So EH care manager, psych consult, the PCP and their staff, and then of course the patient. How integral has the requirement for integration with the electronic health record been, and how's that experience?
I will tell you, that's what started our whole conversation, as you recall, Chris, with NeuroFlow. In a primary care office, workflow is everything. If you get off schedule by 15 minutes as a primary care provider, your day is out of control. People start to back up. So you really, it needs to be one of the most efficient practices there is. And when I was first looking at collaborative care, because I knew it was a model I wanted, in talking with colleagues that have done this, a lot of folks are doing this paper and pencil. But the last thing I wanted to do was to have a patient in a waiting room, fill out a screening tool, give it to somebody at the front office, have them score it, have them enter it into the electronic health record, and then expect the primary care physician to see that before they go in and meet the patient. It'll never happen. We wouldn't have gotten it off the ground. So that's when we first started to talk with your folks, Chris, is we needed some front end. And that was all we were really looking for at first. Just give us a front end so that we can get the data in the office. We were, iPads in the office was all we were looking for. We realized that we can do so much more. So now we're doing outreach to 30,000 people. Okay,
which is remarkable.
When we're through with working through our entire populations. So that helps us identify folks who actually meet the criteria for treatment before they come into the office. Which is ideal, much better than an iPad in the office.
A common theme that I hear of a concern, maybe concern is too strong, but a thought that comes up when speaking with health systems about this and using technology to support it is, what about the liability concern? Is the PCP equipped to handle this? And
in our discussions with physicians, whenever we brought Dr. Brown in, that question inevitably comes up. So what happens when Dr. Brown makes a suggestion about a medication change,
right,
and makes that suggestion to the primary care provider? The primary care provider makes the medication change. If there were an adverse effect, who's responsible? And the fact is that in these consulting models, there is a shared responsibility.
right.
So if it were a significant adverse effect, we would let the courts decide, I suppose. But it is a shared. It does not fall fully with either partner. I will tell you that the kind of responsibilities are less acute with the therapies being provided by our master's level counselors. The tools are not as powerful, but they're also not as potentially damaging, right?
Right.
So we as long as we're managing HIPAA and not doing anything unethical, then we're fine with those. But people do have those questions when you get into medications. I will tell you though, our providers, I think, will eventually, as they get a better comfort level with the consulting psychiatrist, eventually will feel much more confident in having that professional with that specialty sitting by their side.
Exactly.
And I've reviewed a lot of the notes that are coming over already. And it's very important that Dr. Brown, if he's making a medication suggestion, that he's going to tell you what your next step is going to be.
Right.
What are started at this level.
Right.
We're going to sit here for 3 weeks. We're going to come back in, and based on what we see in 3 weeks, we're going to decide where to go next. And I will tell you, no primary care provider ever got that from a psychiatrist.
Right.
Where someone says, "Oh yeah, I'm going to get back with every primary care provider and let them know what medication changes I'm making and why."
Right.
They're really part of the team now.
Except these challenges with behavioral health still existed in primary care. It's not like they're just manufactured today.
No, and we come to find out as we do outreach to patients who had clinically significant screening scores, we talk to them.
Right.
They're seeing a psychiatrist. Primary care provider had no idea they were seeing.
No idea, and
didn't know the medications they were on.
Right.
Yeah. So it does give a whole lot of support to the primary care provider, but it integrates the treatments. And one of the things, if we do refer out to a psychiatrist or another therapist, we keep that person in the loop. So there's a case management role that stays on. We're hoping even after the patient graduates from our
right.
intensive work and billable work and collaborative care. And that's where NeuroFlow comes in as well, because NeuroFlow is not just the screening repository, and it's not just pulling the screening data into the electronic health record. It also works with us to track progress, but then to make suggestions for certain treatment modules that are available for the patient to do in self-management. Now, if someone is interested in mindfulness, deep breathing techniques for anxiety reduction, cognitive behavioral therapy, and models for depression treatment, those are supported by NeuroFlow. The way we have it worked out is not just a self-selection, but our therapists actually pick the modules, direct the patient to them, and then monitor the patient's use of those selected modules. So we're not just going to barrage them with all the tools that NeuroFlow has available. We're going to pick the ones that the therapist wants to try now.
More precise.
See how they work.
Yeah. I think one of the cool things, and our goal has always been, John, you know this, is technology, especially in a case like this, it should be a 1 + 1 = 3 argument, where we're not replacing the humans, but rather augmenting them and helping them do their job more at scale. And if we could help, if we could help you achieve that goal even quicker in terms of year over year, I mean, that's
exactly. And you know, a good point. We're looking at goals.
Right.
CMS and the payers are looking at minutes. Now, the minutes that an individual uses on their own in their home, self-managing by using the NeuroFlow tool, those minutes don't count for the minutes that CMS have, but they certainly count to getting you to your objectives, right?
Exactly.
So if they're reducing your symptoms, that's a great thing. We'll pick up our minutes where we legitimately will, right? But also when a patient graduates, we can send them off with the NeuroFlow tool, continue to have them interact with that, and
Right.
continue to pick up assessment data to say, wow, Mrs. Jones is now back into a clinical range where she showed marked improvements, but now 7 months since we've seen her, she's either an event has occurred or something has happened here. She's back up into somewhere on the high end of moderate levels of depression as measured by PHQ-9. Let's jump back in.
Now,
So
interesting.
in contact.
Because you brought up minutes and so forth, the time that it takes to go to assign the different modules or to review the data, that counts.
That all counts.
Yeah, exactly.
Yeah, it doesn't have to be face-to-face with the patient, as long as it is patient-centered. It could be speaking with the physicians. It could be doing the documentation. It could be analyzing the patient's progress. All of that goes in. We have a little bit stricter requirement. We can right now because we're just growing our caseloads, but we have a minimum requirement of 2 patient contacts a month. Now Medicare is, I believe, once a month, but we're looking at 2 a month is what we would like to see.
So John, anyone else watching this in health systems or payers or provider groups that are thinking about the collaborative care model, is there any other type of technology or administrative items that you would advise them on or they should be aware of?
There certainly is, and we'll see this in collaborative care as it's defined by CMS. CMS wants to see a patient registry so that you can track progress. And I think you've got some inkling with the numbers that we've been tossing out here. The caseload size for each behavior care manager can grow up to 80 and 90 patients. So if you take that many patients and you multiply it out over 4 sites with 5 treating professionals, that's a lot for a psychiatrist to wrap their hands around. We're talking about easily having 500 patients on caseload. So how do you manage 500 patients? Right? Keeping patients straight really does require some computing muscle. We've got to be able to see who's making progress from when they started to what their current screening scores are, who's more importantly, perhaps is who's not making progress or who may be actually showing symptoms that are more severe, they're in a decline. So managing that plus keeping track of who's on what medications, we need a bird's eye view of doing this. And that's what a registry does. So we're still struggling in our initial stages of doing this with fairly rudimentary registries in Excel. There are some things that are available, but that's where we're really excited to see what you guys are working with, Chris.
Exactly. Yeah, we're excited about that, John. Taking the cloud-based, we live in 2021. There's so many different technologies out there. There's no reason not to apply that same sort of technology to helping you with your registry, which is, we're proud to be able to co-develop that in a way to get your feedback in terms of what you need and what you don't need. And then, I think a big part of this and why technology can help us help you adopt the collaborative care model more efficiently is not using a registry just for the 500 patients that are enrolled, but keeping the folks that, graduate out, be, passive in that. So if they come back, you already have that previous data on them, right?
And that gets into the whole notion that you guys have been working with so well in terms of risk stratification.
Right.
So we've got data on people that declined the service, but we still have a PHQ-9 score out there.
Exactly.
So if we circle back around with them, we actually have some longitudinal data to be able to see how they've been managing over time. So the registry can add a lot of power. And we're thrilled to be able to work with you to tailor this to our needs, because frankly, if it's going to work for us, I'm sure it'll work for other collaborative care folks out there, and it's a growing number. I can't go to a behavioral health workshop and not hear a lot about collaborative care models now. It's super promising. In fact, it's already delivered on the promise for so many people.
I'm really excited. It's about time now with 80 peer-reviewed studies and this being around for about 2 decades that more health systems are adopting this. we're proud to now work with dozens of systems with this model around the country, but especially proud of you taking that leap and being that thought leader down in Florida. And congrats again on just in 6 weeks, the progress that you've had.
It's been thrilling working with you guys, and it's been a real responsive team. We've changed this so much from when we started our first discussions, and you guys have brought so much to the table that's delivering on things I didn't even imagine we were going to wind up doing. So we couldn't be more pleased, and we're looking forward to continuing with you guys.
Thank you, John, for joining us today in this fireside chat. Thank you, everyone, for joining us. John, if someone has any questions about the program or needs some tips, where can they find?
You can find me, John Eiler, JOHN Eiler at HF. That's EILER at HF.org. Happy to respond to folks.
Thanks, John, and thank you, everybody. My name is Chris Molaro. I'm the CEO of NeuroFlow. You could reach me at chris@neuroflow.com, and we look forward to the rest of the conference here hosted by Solomon. Thanks, everybody.
Goodbye.